Well, hello, everyone. My name is Tom Lenz, and I'm sorry I can't be with you today to do this in person, but felt like doing a recording of the same presentation might be helpful as we do a little bit of an orientation into what compassion science is and compassionate care in medicine looks like for our new initiative here in the School of Medicine at Creighton. I thought it might be probably a good idea just to do a little bit of introduction of who I am and why I'm standing up here in front of you talking about this. So my name is Tom Lenz. I've been at Creighton for a number of years, about 25 years in a faculty position. And about 3 years or so ago, I came over to the School of Medicine, and I'm the director of a master's program called Integrative Health and Wellness. The story is longer than short about my, academic background and all that business, but and too much to bore you with today. But most of my, I felt like this would be important information anyway. But most of my research over the last probably 10 years or so ago has been in chronic stress, and that has led me to look at healthcare professionals' burnout relative to chronic stress. And that actually has led to this new initiative in compassionate care. And so we wanted to put this, infuse this information into the family medicine clerkship for you all. And so this is our introduction to that today. And you'll be working with your M4 chiefs throughout the next 8 weeks to talk about some additional information relative to compassion and how we work with patients in this relational care way is how we say it, and what that can mean for both you and what it can mean for your patients and the system. And but this today is an introduction into what that is all about. So hopefully after watching this video that you can get an appreciation for where we're going and why this might be important. But certainly my contact information will be at the end, and if you have questions about this after today, please reach out and let me know. Okay, so what we're really going to talk about to get into this, really an introduction into this, is talking about connection, compassion, and patient care. To get us going on this, it makes sense, at least in my mind anyway, to lay a foundation in chronic stress, what burnout actually is, and then loneliness, and we'll dive into that a little bit deeper as we keep going today. But it tends to make sense, I think, to give some baseline of what stress looks like. So just very quickly, this is pre-COVID numbers that stress affects about 43% of adults, and interestingly accounts for about 80% of all primary care office visits when you look at this from a broad perspective. And so according to the American Psychological Association, that it's a significant factor in about 85% of all diseases and illnesses. And when you think about that number, that's actually pretty extraordinary. So we all know we feel stress, and that stress is involved in our personal lives. But part of the point of today is to start seeing this from the patient's perspective, and that most of the people that you be working with throughout your entire career, and certainly in this clerkship, are experiencing some kind of stress. Looking at this, though, that was pre-COVID numbers, and then what does stress happen? Of course, we know this is shortly after COVID, so at least when this data was collected in 2023, that in nearly every age group, that stress increased from COVID. And we need some updated numbers to compare and put another line on here so we can see what 24 looks like when we get that data. But I think it's still fair to say that stress is greater now than it was pre-COVID in general. And you can see the age demographics of how that breaks down. So nearly every age demographic except for 65 and older, which is about the same. Just in August of this year, our Surgeon General, who's doing a great deal of work relative to healthcare professional burnout, chronic stress, and loneliness, put out this document that talks about stress in parenting and how parents are under more stress, just as not really a subgroup, because it's most people, but a subgroup of the population. Looking at parents, 41% of parents say that Most days they are so stressed that they cannot function. Okay, so that's significant for healthcare professionals to think about this when you're seeing people in the clinic, this over the next 8 weeks in family medicine, that if that person's a parent, 48% say that on most days a week their stress is completely overwhelming. So you're looking at almost half of the people that you're talking with. And that's compared to other adults who are not parents at 20 and 26% respectively. So it's something to keep in mind. It's a new document that I wanted to expose you to, and that's why I put it into this talk today. But looking at this from a healthcare professional standpoint, so looking at you as a healthcare professional now and looking at your colleagues as healthcare professionals. So let's think about it just from a physician burnout perspective. And you may be familiar with physician burnout in some regards, or at least you likely have heard about it anyway. And certainly maybe some of you are feeling it as student physicians. But the characteristics of burnout is really any one of these three characteristics. Okay, so you're talking about emotional exhaustion, depersonalization, or sometimes you see cynicism substituted for that language of depersonalization. But this is where you have a difficult time seeing that the patient you're working with is actually a person, that you look at them somehow other than being a person. And that changes fundamentally how we care for others when we disassociate the person from the patient. And then thirdly, a diminished sense of personal accomplishment, where you could have had, the greatest day, at work, and you go home and you just didn't feel like you did anything meaningful at all, even though you made a difference in people's lives. So burnout would be, you don't have to have all three, you could just have one of these. So keeping these characteristics in mind, here's the prevalence of burnout, and this is just for physicians, and looking at it from when this data was starting to be collected and monitored in 2011 up to 2023. So you can see how we peaked in physician burnout during COVID, and that completely makes sense. So 63% of physicians said they had at least one of those symptoms of burnout, and that compared to 52% of all healthcare providers combined. And we fortunately have come back a little bit. And the prevalence is not as great now as it was during the height of the pandemic. So thank goodness, but certainly not to the level we were pre-COVID, though, at 38%. So keeping this in mind, nearly half of the people who, when you go into your hospital or clinic, nearly half of the physicians that you see are experiencing some level of burnout. Why do we care? Well, the data is pretty clear on this, that it leads to poor quality of life. For physicians anyway, at 2 times higher odds of making medical errors. So if you just have one of those characteristics of burnout, then you're 2 times more likely of having a medical error. It costs the system about $12 billion annually. And this is mostly because people who experience burnout feel like they're seeing something better somewhere else. And so that causes providers to then want to change jobs and go somewhere else because it must be better over there. And what typically, and sometimes it is for sure, but many times it's not because it's a larger issue. And just a little trivia for you, if you ever wondered how, in today's dollars, how much money it costs to replace one physician. So as you get out into practice and you decide to leave, your institution will pay about $1 million to replace you. That's an average cost for physician turnover per person. And then most significantly, and this is what rightfully so gets a great deal of needed attention towards this, is physician suicide. And so you can see how the odds for physician suicide is much greater than the general population. And this is the thing that's most concerning about physician burnout. In 2023, as I mentioned a little bit ago, the Surgeon General has been keeping very close tabs on loneliness and isolation, and looking at that as a risk factor for for lots of ailments, and bringing light to how important this is for our general population. Now, this document isn't specific to healthcare professionals, not specific to physicians. We're talking about this for the general population. And I remember when so maybe you've seen in my my little bio thing there that I'm a pharmacist. And when I finished pharmacy school, I did a fellowship in cardiovascular research for a couple of years here in the School of Medicine and Cardiology. And I remember during that fellowship, I came across an article that said that the one of the most significant emerging risk factors for middle-aged men was loneliness. And now we're talking about in the late 90s, early 2000s when I read that article. And I thought it was interesting, but there really wasn't a whole lot that I did to follow up on that. But then fast forward to about, so I can do the quick math in my head, about 15 years later or so, 10 or 15 years later, I was working in a program we started at Creighton for our employees as a lifestyle medicine program. And it is for, because it's still running, for our employees who have high risk for cardiovascular disease and had risk factors for that already, like high blood pressure, high cholesterol, diabetes, obesity, and so forth. And one of the people I was meeting with in that, and by the way, the program, people can stay in it for as long as they want. They just have to see the person they're meeting with, like me, once a month to help manage medications and lifestyle behaviors and work through risk factors and so forth. And so I'd been working with this gentleman for about a year. We saw each other at least once a month for these visits, and the visits were at minimum 30 minutes of time. So we got to know each other pretty well within that 1 year time period. And I remember when he came in this one particular time, and as we were sitting down and getting ready to have a conversation, he said, "I've got it figured out." And I said, "Of course, what do you mean? What do you have figured out?" And he said, "I know what the root cause of my health issues are." And again, this guy, two PhDs, really high level researcher. You look at him from the outside, from his CV, and it looks like he's got everything together, but he's struggling. He had high blood pressure, high cholesterol, yeah, the whole thing, diabetes or pre-diabetes, I guess, and obesity. And he was right where you want people to be in a program like this, where they start understanding their patterns and being able to figure out how, for themselves, how they can take charge of their own health. And he said he had it figured out. So I was, of course, very interested. I remember leaning forward towards him saying, "I can't wait to hear this. What is it?" And he said, "I'm lonely." And this guy was, at the time, he was in his upper 50s, and I didn't know what to do with loneliness. I kind of sat back in my chair. I remember slumping a little bit in my chair, like, oh my goodness, my whole career up to this point is on biomedical reductionism, right? I mean, like, I understand why he's pre-diabetic. I understand why his blood pressure is high, and I know there are strategies for that, both from a pharmacologic standpoint, but also from a lifestyle standpoint. And those were my answers up to that point. But when he came to me with, "I have it figured out, that my root cause of my health issues is loneliness," I didn't know what to do there. And it certainly reminded me of back when I read this article many years before about an emerging risk factor for middle-aged men, and this guy certainly fit the profile. And so fortunately we are, and what that ended up doing, just to complete the story, is that it caused me to go back to school. I went back and got a degree in medical anthropology because I needed to know more about what was going on in loneliness and all the larger social factors that influence people's health. And so I'm really grateful for the Surgeon General in putting attention and light to this issue on, I think rightfully called, an epidemic of loneliness and isolation. And how can it be that we live in a society that's more connected with technology than we have ever been in our history? but yet we are more lonely and isolated than ever before. I think that says something about what's happening. But from a national trend on social connection, and this is where this topic goes at this point, is social connection, but looking at all of the factors related to connection, like isolation and household and social engagement, companionship, social engagement with friends, non-household family social engagement with others. All of those are trending in the wrong, if not just trending, but you can see how some of them are very significantly going in the wrong direction. So it looks like almost every marker we have on social connection is going in the wrong direction. Interestingly, I think this slide is one of the most interesting I've seen in a long time, looking at what is the significance of social connection relative to the other risk factors that we typically think about when we think about risk factors for conditions like cardiovascular disease and others. But lacking social connection shows to be, and it's not statistically significant, you can see how the lines cross for smoking, but it is for the other conditions, but certainly trending higher than smoking and more statistically significant than drinking 6 alcoholic drinks daily, physical inactivity, obesity, air pollution, that a lack of social connection has that much of an impact on our health. And so I think that's something for us to pay attention to in the light of all of this conversation that we're having about connection and compassion. So let's go a little deeper into maybe some background about this for connection. And back in 2009, Christakis and Fowler wrote this book called Connected, and where they looked at social networks. And you might think about your social network as, and there's many examples in our lives, like your medical school class is a social network. Creighton University is a social network. Omaha, Nebraska, United States of America, or your clubs that you belong to, or maybe a sports team that you're on or were on in the past, or maybe a band or so forth, or your church group. So there's a lot of examples, and certainly your family is a social network, also has its own social network. We have a lot of social networks we belong to, and the dynamics of these social networks is what Christakis and Fowler were actually looking at. And thinking about what they look like, what they discovered was that they actually look like this. And so it's a really interesting dynamic structure here, where you can see, if I can, point to these, you have this person who's the A dot here on the lower left, where how many connections they have. Direct connections is 1, 2, 3, 4. And those people have connections to other people. And then those people have connections to other people. And sometimes they're connected back to the same people, and sometimes they're not. And so that's one way to look at this. And the other way is to look at where some of these people are within the network. And you can certainly see in the middle, there's a concentrated amount of people who are connected together at the center of a network, where you have other people who might be on the outside of the network, maybe have only one person that they're connected to, like over on the very far right here, where there's just one particular connection and those people are way out on the outside. So some people like to be on the inside of networks, some people like to be on the outside of networks, some people are forced into either. But the point of this from Christakis and Fowler is that these networks change over time. And networks are, or connections between people are made and are broken. And so that shifts over time. But importantly, that the network has an effect, the network overall has an effect on each individual that is within it. But also each individual within it affects the entire network as well. And so some important rules with social networks that they came up with is that all networks, regardless of what type of network they are, the context of the network, has the linkages are what's important. There is a connection from person to person, and there's something that happens within those connection that causes a flow, or what they called a contagion, which means that one person in the network influences the people they're connected to, okay? And that's the really important part about thinking about our connections and relationships as we think about them with our patients or with our coworkers or with our family or friends, that there's something that transfers from one person to the next that has influence. And what they found is that about, well, first of all, this first statement is pretty incredible, that on average, there are about 6 degrees of separation that connects everyone on the planet. So if you look around the room right now and you're looking at people sitting next to you or in front of you or in back of you, that if you just go out to 6 people, so the person next to you is one, a first degree connection, the person sitting next to them is a second degree, and then next to them a third degree, and so on. You can just count out to 6 degrees of separation. And on average, and this is a whole talk I think in itself, that the whole planet is connected by on average 6 degrees of separation. And there's actually studies and then replicated studies to show this, and I think that's super interesting all by itself. And those were actually done pre social media. So this, I would suspect that social media has an effect on the degree of connectedness that we are. But it's safe to say, whenever we use the phrase, boy, this is a small world, small world we live in, it really is. We're connected to a higher degree with each other than what we realize. But what's important for our conversation today is the second part. We're out to 3 degrees of separation has a statistically significant influence. And that's where my point a minute ago was to say that within your social network, there's something that happens from one person to the next that flows, a contagion, as Christakis and Fowler called it, that one person influences the next. And it goes out to 3 degrees of separation. So as they say in their book, a friend's friend's friend has a statistically significant influence on that person out to 3 degrees of separation. So what does that actually look like? And what they discovered in all of their ways of measuring this contagion or this influence is that it happened in attitudes, feelings, and behaviors. So things like political view, weight gain, happiness, creativity. And they didn't study compassion, but I would say, and I'm just going to hypothesize, I think that compassion would be in there too, that one person's compassion has a statistically significant influence on people out to 3 degrees of separation. So what does that look like in their data anyway? So looking at weight gain, for instance, so the person sitting next to you is a first degree social connection to you, like they're your friend, okay? So you see that person frequently. That first degree person to you has a 45% influence on your body weight and you on theirs. Okay? And from a happiness perspective, they have a 15% influence on your happiness and you to them. Super interesting, right? Okay, so going out to another degree, so their friend, so that person sitting next to you has a friend, and you may not even know that friend, or maybe you do, but that person, you have a 25% influence on that person's body weight or weight gain, and a 10% influence on their happiness. Go one more further degree, a 10% influence. And you may not even know that person, as I mentioned, that friend's friend. You may not know who they are, have any contact, never heard of them, never see them. But you have an influence on them more so than what you realize in things like weight gain and happiness. And I always like to add this. If you don't think 3 degrees of separation has a statistically, if 6% happiness is statistically significant or significant by any means, if I gave each of you $10,000, it would increase your happiness by about 2%. So that 6% is meaningful. And it's out to the 4th degree where this loses statistical significance. It doesn't mean that there isn't an influence there. It just loses statistical power out to after the 3rd degree. So what would this look like in a hypothetical scenario? So if your social network, thinking about that image of a social network, if you had 20 social contacts, you had 5 friends, 5 coworkers, and 10 family members that you regularly were in contact with, and then each of those contacts had 20 contacts, and this hypothetically would be no overlap. And I know that's not always possible of course not possible with coworkers always, or family members, but just hypothetically. And your network is probably a lot bigger than 20 people in general. that your 3 degrees of influence is out to 8,000 people. And I would argue that a healthcare professional like a physician probably has, be someone like a physician or a healthcare professional or a teacher would probably have a much greater influence than some others because of the number of people that you come in contact with on a daily basis. So 20 social contacts may not even be close to what your social contacts, maybe you have 60 or more. But the point of this slide is for you to perhaps wrap your head around how much of an influence you have on other people related to your happiness, your health behaviors, your political views, your sense of altruism or helping other people. Almost every way that Christakis and Fowler measured was consistent in that 3 degrees out had an influence on behavior. So we are connected in ways that we don't really even think about probably or realize from a social side. Taking this a little bit further, there's a one of the largest, or not, it's not one of, it's the largest study that is currently been undergoing here in the United States is the Harvard study of adult development. It started in 1938, and it's still going today. And so here's a little bit of data on this, but the point of why I have this in here, their single research question for this is what makes a good life. So just to give you some perspective, and it's a little overwhelming actually with thinking about how much data is involved in answering that question, but it began in 1938, so it's still going over 80 years. There are 724 original participants. And then they, of course, measuring have the descendants, many of the descendants of the original participants involved in the study now. So there's thousands of points of data that they're looking for. And as you know, when you look at statistics, the more data that you have, the more predictive power that you have to answer questions like what makes a good life. And so looking at regression equations and factoring out all of these, what we might typically think of what makes for a good life, like how much money you make, what your genetic factors are, where you live, what kind of education you got and where, factoring all those things into this question, the one factor, of course, that you can see at the bottom that consistently comes out of this data is that relationships are the single most important factor for what makes for a good life. And I think there's a story to tell with that. I mean, of course, I'm trying to build the case with this information today. So there's something for us to pay attention to about our relationships with our patients, with our coworkers, with our family, and even with ourselves. But this probably shouldn't be so much of a surprise for us because our natural world really is connection. There are examples everywhere about how the natural world operates based on connection. It couldn't happen in isolation. There isn't anything you can think about in the natural world that is actually going to work if it's not connected to something else. It's one big story of connection, our natural world is. And so just a couple very simple but dramatic, I think, examples of this is the iron story. If you haven't heard this before, elemental iron can only be so elemental iron we know is an important part of our life. We have it inside us, and it's important, as you know, for the transport of oxygen around in our bloodstream. We need it in our diet, and if we don't, we need to supplement it. It is part of the food we eat in both plants and animals. It's part of the core of our earth, iron, elemental iron. But it isn't created. It is we can only get elemental iron, of all things, here's a trivia for you, from an exploding star. So a supernova exploding in the atmosphere and releasing gases and particles out into the atmosphere, into the cosmos. And billions of years ago, this happened for us in the earth, and gravity pulled it together. and we have the earth as a part of that, and core, elemental to the earth, or fundamental to the earth, I should say, is elemental iron. And so there's a connection story there. What exists inside of us is connected to something that happened billions of years ago. And I think that's an interesting story all by itself. Electromagnetic fields of energy are nearly everywhere and in everything that is living, including yourselves, and that we emit an energy field out from ourselves, and we can measure it. We have ways to measure this out to about 6 feet or so now. But we know that this travels further. The energy, the electromagnetic energy that we emit from ourselves and that we get from animals and plants and the sun, travels great distances and has an influence on how we feel. And so we know that, just for instance, when we enter a room of people and we can feel the energy in that room to some degree. Sometimes it feels light and joyful and happy. Sometimes it feels heavy and stressful. And that's because there's an energy and a wavelength to that energy that we naturally pick up and are able to interpret in ways that a lot of times we aren't even conscious of. And so there's a connection story there too, that sometimes we just feel like we need to be face to face with someone and talking, and that's the way we make connection. But certainly we know there are other ways. And then quantum physics may be the most interesting out of this, at least for me personally anyway, and that there's a part of quantum mechanics that is called entanglement. And that this is something that Einstein, of all people, discovered along with some colleagues about 100 years ago or so, but didn't quite like what he was, I guess, maybe not sure how else to say it, but he dropped this notion of entanglement because he called it spooky action at a distance, and it didn't make sense with the other things that he was studying. So he left it go, but it was actually proven to be true that subatomic particles are entangled, and this happened in the 1950s, where it's shown to be not just a theory but a real thing, and that so we can have two subatomic particles that are connected so intimately that if one particle changes, the other particle will also do so simultaneously, and they don't have to be even in the same space, or they don't have to be even in our notion of what time, how we figure time. So the classic example is you have something that happens on Earth and has an entanglement. So you have perhaps where a light bulb, for instance, might go on here or flicker here on Earth, and if that photon in that light bulb was entangled with a photon that was in the farthest galaxy, that it would flicker at the exact same time. And so this is how, just FYI, how quantum computing is working and developing, and that scientists are figuring out how they can entangle particles purposefully to make information travel so fast. But I wanted to show you this image because just this summer, this was the first image of what two entangled photons look like, and strikingly similar, as you might have recognized, to yin and yang. And so I think there's something there for a relationship story for us. There's a story about connection to be told, that connection happens in ways that we often don't think about and really probably aren't even aware of, but it's certainly part of our natural world, and we are part of that natural world as humans. So it just naturally makes sense for us that there's something really important about connection and relationship with each other. And that, I think, has a lot to say about compassion. So bringing this conversation then back to the person-to-person relationship, or relational care, as I often like to say, or maybe even more so, my favorite is relationality, which is the relational exchange. That there is the flow that Christakis and Fowler were talking about that happens between people in a social network. There's something that happens there. I think that where if we look at it as an exchange, where we are giving something away to them, and let's say we are giving them compassion, offering someone compassion, if that is then received by the other, by the person, that person then in turn gives something back, and then that is received, and then you have this back and forth flow or dance, if you will, that we have this relational exchange occurring. This is where I believe, with the data that I'm about to show you on the importance of compassion, this is why I feel like this makes sense, is that there is this continual flow. But something has to be offered and accepted, and then offered and accepted back again. And let me just give you one quick example of how the flow can stop so quickly. So let's just say you have a patient, and you probably experienced it already, and if you didn't, you will soon, that a patient or a family member says to you, "Thank you. A genuine thank you. I really appreciate the care you gave me," or "You really appreciate the care that you gave my mom, or my dad, or my grandma, or grandpa, or whomever," right? My son, daughter. If you respond to that giving that the person is offering you with a response of, "Oh, it's all right, don't worry about it, it's just what we do here," it's essentially stopping the flow. And if you think about this in an exchange way, where if you just put the hand up, and because that perhaps made you uncomfortable, which likely it does for a lot of people, that you don't want to be in that position to feel like that somebody's thanking you, you just sort of play it off. That stops the flow, and that individual who offered that to you then gains nothing in return. And we don't do it to gain something in return, but you didn't get the benefit because it wasn't received, and nor did you, just by you receiving it, then was given something, you're giving something back to the individual. So if you would respond in a way that says, "I really appreciate you saying so, that means a lot to me. I love my job and I love helping people, and your mom was such a gift for me to work with," that is offering something back to them. So not only did you receive it and internalize it and experience something meaningful there, but now you're offering something back to the person who originally gave you the thank you, and they're then receiving as well. This is the flow. This is the relational exchange that can happen in a compassionate care setting. And this is what we're talking about, where if this is happening, if the exchange is happening, then this data that I'm about to show you is going to make sense. So there are two physicians, Teresiak and Mazzarelli, that published this book in 2019, and you may have heard about it already. If not, it's a great read, and I would recommend it to everyone, Compassionomics. And what it does is essentially they scoured the literature and did a synopsis of all the literature related to compassion, and were able to come up with some very interesting conclusions, but did a great service for all of us in that they compiled the data in one place. Okay, so Compassionomics, as they call it, really is this, what they define compassion as, an emotional response to another's pain or suffering that involves an authentic desire to help. And this is the reason I italicize that, is that there's an action involved. Okay, so when we see, so an empathetic response is that you can recognize that someone's in pain, and you can feel that even yourself, that they're in pain. The difference between empathy and compassion is that in compassion you actually do something about it. Okay, you offer something to the person who is suffering. That's a compassionate response. You first have to have empathy, right? If you don't have empathy, then you can't even recognize that there's suffering going on. So that's step number one, and it's important. But the difference is that in compassion, you have an authentic desire to do something about it, to help the individual. And the reason I put a little star there is that a lack of compassion, or a lack of connection, I should say, such as in our current state of loneliness and isolation, is really the suffering of our lifetime. And I think that's no small statement, and something I think to think about for all of us. Is that this notion of loneliness and isolation is really a suffering that most people are living through. But back to our compassionomics, and specifically looking at from physician standpoint, is that 70%, this comes from Teresa and Mazzarelli's literature review, 70% of compassion opportunities are missed by physician. And certainly that would be compounded by burnout. Okay, that we're not even having the capacity to probably recognize, and that would, of course, be related to empathy. But maybe you have the empathy, but then you just don't have the authentic desire to help. Okay, so 70% of compassion opportunities are missed. And the reason for that is 56% is the largest largest factor, is that physicians don't believe they have enough time to be compassionate. But one of the things that is really the take-home message from Compassionomics is that what they've been able to show, Teresa and Mazzarelli, through literature search, is that it only takes, on average, 40 seconds of extra time to deliver compassionate care that makes a significant difference for the patient. Okay, so keep this in mind. It was a great TED Talk. If you want to look at it, it's Teresiak's TED Talk on 40 seconds of the power of 40 seconds, it's called. So some of the outcomes, anyway, from compassionate, so physicians who score high on compassionate care scales for their patients who have diabetes, those patients experience an 80% higher odds of blood glucose control, normal cholesterol, 40% lower odds of diabetes complications that place them in the hospital. That is no small numbers right there, of course, as we know how significant diabetes is. And looking at folks who have HIV, that 33% higher odds of just taking their medications. And as we know, that's one of our most significant hurdles in chronic disease, is just getting people to take their medication. From a surgery standpoint, there's less sedative before surgery, fewer pain medications after surgery, and discharge sooner. And we know how significant each of those factors are. And then there is a whole separate chapter in Compassionomics, too much to get into today, about the overall effect on the healthcare system from a cost perspective. So it costs the system less money overall when physicians are more compassionate. And part of that is when the patient knows that you care about them, they are less likely to have any litigation against you. When they know that you're doing your best and that you're caring for them at your best, and that you actually, that you matter, that the patient matters to you, they're less likely to have any litigation if something goes wrong. Okay, so the literature demonstrates that this can be taught. Okay, so sometimes people would think, well, I don't really have a predisposition to be touchy-feely, and that's not what we're talking about. Compassionate care is not touchy-feely care. It can be, for sure, but it doesn't have to be, and it certainly isn't that way by definition, and I'll show you what that means a little more clearly here in a minute. But the old traditional philosophy of don't get too close to a patient because it's going to lead to exhaustion and burnout. This book conclusively shows, this is one of the conclusions, is that compassion, in fact, is an antidote to burnout. And that it's not where the data shows that the antidote to burnout is something like escaping from the situation. It's actually the opposite. It's greater engagement. Connection and relationship matter. And again, that's why I showed, the Harvard study on adult development, the largest study that's been done in the U.S., shows this same thing is the case, that relationship is what matters. It's everywhere in nature. It's what Christakis and Fowler showed in their work too. Okay, so connection and relationship matter. And of course, that from a healthcare professional standpoint, but it's really interesting to see the data show us that. It's not just a feeling that we have. The data shows it. So greater compassion leads to less fatigue and burnout from a healthcare professional standpoint. This is the point of this. It not only leads to greater outcomes for patients. The patients do better, the system does better, but in fact, you do better as well. So what does this look like when we combine this with this conversation about an exchange, a relational exchange? Well, we can look at this on several levels, and we're not going to go into detail on really any of these because it's just a conversation for a different day. But having this relational exchange at an institutional level would probably make the system overall work better, where both the institution and the people who work at the institution had a back and forth exchange. Our own interior work and our personal exchange with ourselves is a relationship we have with ourselves that we need to really pay attention to. And I think it's not taken as seriously as we need to in all of the methodology we have and the strategies we have for self-care. We haven't really done that in a serious way, I don't think. And so there's a level of relationality or relational exchange we have on a personal level. And certainly transcending compassion is the only word. It's a word I'm using in this situation where we have a relationship with our patients, our coworkers, and our family, of course, and our friends, and the nature and environment and how we have this exchange there too. But compassion happens through a relational exchange. This is kind of a concluding statement, although it's not really trying to conclude much of anything here, of just but recognizing patterns here. And it occurs as a result of authentic desire. Okay? Our authentic desire to offer patients compassion through this relational exchange is what we might call the secret sauce. So can we, as healthcare professionals, put ourselves in a position or a posture, if you will, both as a noun and a verb, to be present to the relational exchange? Can we recognize that there's an exchange going on there? So let's look at this from a patient care side. I just want to tell a really quick story here. The Princeton Theological Seminary did a study that they call the Good Samaritan Experiment in 1973. And so what they did was had people who were training to be seminarians and put them in two groups. One group, and by the way, everyone in the cohort, everyone, in the one group, and I don't want to make this too complicated in study design because it's not the point of this. So one group was asked to read the Bible passage on the Good Samaritan. And if you remember how this goes, that there's an individual who was beat up and robbed and left to die on the side of the road. And there were people who passed by who were supposed to be that person's on that person's side, as far as, friends and like-minded people and some of the same people. And they just walked past the individual. But the one who you wouldn't expect, the Samaritan, was the person who stopped and helped the individual and cared for them. Great example of compassion. But what they did for this study was they had seminarians read that passage and then ask them to prepare to answer questions about it and to explain it and to give, kind of not necessarily a sermon, but they were asked to have some thoughts about it and discuss and be prepared to discuss it and so forth. So they had to read it and they did certainly some reflection about it and some preparation for that. One of the groups then, what they had them do is they were split up into groups where one of the groups was made to feel like this questioning and sermon, if you will, that they were supposed to give was in a building that was a different one. And they were made to feel like they were pressured for time and that they needed to get over there in a hurry and be able to make their way over there because they were waiting for them. Okay, so that was the one group. The other group, they said, well, they're not quite ready for you, but you may as well just make your way over there, but you don't have to be in a hurry. So they made a hurried condition and a non-hurried condition. The point of this was about perception of time. One group felt like they didn't have enough time. The other group felt like they had enough time or plenty of time. They weren't in a hurry. Really important, obviously, as you can tell, for our conversation for this and why I'm bringing this in, because 56% of physicians say they don't have enough time to offer compassion. And you've certainly been around medicine now long enough to know that there's a time urgency most of the time. Okay, so how did this play out? Well, keeping in mind that these are seminarians who are going to school to be leaders of a spiritual group, a faith-filled group, and that they had in mind the Good Samaritan story. Well, on their way from one building to the next, they had planted an actor who was to then act very similar to what was described in the Good Samaritan, where someone was hunched over and was moaning when they went by and looked like they were some degree of suffering. So each person had to pass by this person on their way to the next. And the group that felt like they were in a hurried state, just 10% of them stopped to help. Compared to the group who were in the unhurried state, 63% of them stopped to help. Now, the point of this is not to say, how come why didn't 100% of the non-hurried people stop to help? That's not the point of this, although it's a question you could ask. But that there was a significant difference when we feel like we are hurried. Okay, so this is our important point for this about compassion, is that when we feel like we are in a hurry, we don't feel like we have enough time to do what we are actually called to do, and that is to care for others. Now, on the debrief, I can't help but think about what the moral injury that occurred to all of these seminarians when they were debriefed on what had just happened, and how that might have affected them. And perhaps it goes, we don't have data on that, but perhaps it gives us some kind of insight also into how we perceive burnout, and that it's probably a better way to describe it as moral injury, in that we as healthcare professionals don't feel like we have the time to do what we are called to do. I think that there is really some importance, that's a topic of importance that we need to address and look further into. But anyway, the point of this is that the perception of time. Okay, so what Compassionomics talks about is the power of 40 seconds, and that on average, it takes about 40 seconds of extra time to deliver compassion to a patient that results in a significant difference. So I'm just going to highlight a couple studies very quickly here. Johns Hopkins in '99 did a study on this, where patients who receive a cancer diagnosis from an oncologist, there's a standard consultation versus people who received enhanced compassion intervention. The results are, that the patient felt significantly less anxiety as a result of the enhanced compassion. I want to read through this for you so you get a flavor of what kind of language is used. Because when you say, okay, what does it mean to be compassionate? What does that actually look like? I think this gives a little information to that. It's important for us to just read through these so we can recognize this. So the script goes like this. I know this is a tough experience to go through and want you to know that I'm here for you. Some of the things that I say to you today may be difficult to understand, so I want you to feel comfortable in stopping me if something I say is confusing or doesn't make sense. We are here together, and we will get through this together. And that was the end of the consultation. And at the end, that was at the beginning. And then at the end, I know this is a tough time for you, and I want to emphasize again that we are in this together. We will be with you each step along the way. It took about 40 seconds of time to say those words to the patient. Now they were, I think you can pull out of here the main parts of this that are very meaningful, and these are those words that are connection words. Like I recognize that this is an acknowledgement that this is difficult and this is scary, but most importantly that we are here together and we're going to go through this together, and we'll be with you along each step along the way. That's the connectedness piece to this. That's the connection. That's the compassion, the relationship there that is building. Okay, so let's go to another study in the Netherlands, published in 2014, measured anxiety from compassionate communications for people who were receiving bad news. And for this, they were analog patients, which means that they were healthy patients that had to put themselves in the shoes of patients who were receiving bad news. But the point of this too is that this intervention took about 38 seconds. And here's what they said in this intervention: whatever we do and however it develops, we will continue to take good care of you. We will be with you all the way. We will do and continue to do our very best for you. Whatever happens, we will never abandon you. You are not facing this on your own. Together, we will have a careful look at the decisions you have to make, and we'll keep a close eye on your concerns. Okay, so how great is that? That's compassion language that really makes a connection. You're not facing this on your own. We will never abandon you. I mean, using the language of we, this is us together, doing this thing together. We will be with you all the way. It's fantastically compassionate language. And that's the point I wanted you to get out of these slides. There's a Northwestern University study published in 2012 that looked at the real world. This is mostly just on time studies and looking at how long it took to hear from a patient about their concerns and then respond to those concerns. And this particular study showed that on average, it took 31 and a half seconds per sequence. And a sequence is the patient voicing their concerns and the physician responding to those concerns. Okay. And for each patient, there was a mean of about 2.5 compassion opportunities. So adding those together, it's about 79 seconds of extra time to answer, to hear questions and answer questions in a compassionate way. And then lastly, on this slide here, there's some information about a UCSF study, again, about compassion, how it didn't add significant time that was spent to the patient. And then looking at all of these studies combined, you can see that on a median, this is why they say the power of 40 seconds right there, the Fogarty in the middle, those 40 seconds of time is why they say the power of 40 seconds. That's how they came to it from looking at all these studies together. And then importantly there on the asterisk, enhanced compassionate care was shown to reduce patients' emotional stress up to 6 months after a clinic visit on that one particular study. So then thinking about this back to the Good Samaritan experiment that we were talking about before, in that our perception of time matters, and that we perceive, and there's great time studies to support this, that folks who make more money, have jobs that are perceived as higher esteem and importance, and certainly a physician would fall into those categories. There's a perception amongst people who work in those positions that their time is more valuable than someone who might be answering those time perception questions for having a different type of social status job. So there is this sense of my time is really important, and of course it is valuable and it is important and matters. But the one thing I want you to keep in mind for this is that it doesn't take a great deal of extra time to show compassion to another person, and that many times it's our perception that we have less time than it is the reality of having less time. And so I think if we think beyond the research from this perspective, that it's my hypothesis, and I'm working on designing a study that can hopefully show this, that 40 seconds can be reduced to 0 seconds, because compassion is really a way of being rather than a specific word or scripts or the actions, these prescribed actions when we're with a patient. That if we are with a patient, present with a patient in a way of being that shows compassion, and this is why I wanted to show some of these ways of connection we have with people that is often beyond words, that if we have that way of being with patients, that we can be compassionate just by our way of being, rather than this script that I need to read out that's going, or think about, that's going to, be 40 seconds, or some type of time stamp that's going to be longer than what we want to give credit to. So how do we keep ourselves in that way of being? Well, something very simple is just with breath. Okay, so if you just take 3 deep breaths, and this is, I think, some very good advice that someone told me a while back, and it works. And as they said, 3 breaths 7 times a day, but you can do it during any time. You go in before you enter a patient's room, just take 3 deep breaths and put yourself in a different presence with that person. And that actually, we know that deep breaths have an influence on parasympathetic nervous system, and will actually put you in a better position to both listen to the patient and be able to respond compassionately. So at any point in the day, if you need to reset, breaths are really important. The other things I think that you could do today, if you wanted to start to be more compassionate today, here's some things that go beyond even what were simpler than what we even talked about today. Sit with, when you're talking with a patient, face them first of all, and square up your shoulders to them, as opposed to talking to them where you might be looking at a computer screen and looking away from it. It really matters to square up to an individual and talk with them, and leveling up your eyes. So rather than you standing over the bed, or try to find a chair or something to lower yourself so you can be at eye level. And then really, look at your patients in the eye. It's not like you have to, don't make them uncomfortable in that way, but instead of not looking at them in the eye ever, but as you're speaking with them, look at them in the eye. It really matters from a connectedness standpoint. And then if it makes sense, sometimes just a tap on the foot or on the shoulder, that there is also data to show that those little touches make a transfer of energy difference when you're communicating with other people. And so if it makes sense, obviously don't make it creepy, but if it makes sense, to just give a little touch or tap or something with a patient, that can greatly help. And also knowing your boundaries from a cultural side, because sometimes that isn't acceptable in some cultures too. That's important. And then lastly, I just wanted to touch on this because we put this into this as just a little bonus information, that I know you've gotten information about motivational interviewing in the past, and doing that with patients as a way to talk with patients instead of talking at them. You're talking with them, and that this is really a partnership with people. So sometimes we can get caught up on a script for motivational interviewing also, but in a sense in this, just my tips on this is your presence matters more than anything. Goes along with what we were just talking about, more so than how you frame what you're saying in the word sequence. But your presence really matters, and being your authentic self matters. So don't try to use a communication style that isn't natural to you. Then we're always, giving electromagnetic waves that are kind of sketchy and jumpy, and they don't flow well, as opposed to our natural way of communicating is usually a nice smooth style because we're comfortable with it. And then lastly on here, avoid the writing reflex. We are so used to in our professions of answering questions directly and correctly. And so sometimes we do that, not sometimes, most of the time we have a tendency to do that with patients. And so try to avoid always giving an academic answer that gives too much information. Give enough information to educate, but if you can nudge a patient along to helping them discover what makes sense for them, and helping them and doing that in a very team-like fashion, because you have information and they have the experience. So coming together in a path forward, I think makes a lot of sense from a motivational interviewing standpoint. Okay, so that's it, and that's enough. I know that was very long. But please reach out to me if you have questions or you want to discuss any of this information. I would love to talk with you further about it. And if there's any thing that comes up in your clerkship or your other clerkships, please just reach out and let me know. I'd be happy to have a conversation with you. So let me know if you have any questions, and I appreciate your attention. Thanks.